Thank you everyone for joining us. It is the top of the hour, so we will go ahead and get started. My name is Steve Chen. I am a breast surgeon in San Diego, as well as the Chief Medical Officer in Pedimed. And I want to thank everyone for taking time out of their day to join us on this webinar. Joining us today are two breast surgeons from across the country. The first is Allison DiPasquale. Dr. DiPasquale is a breast surgeon and the breast oncology director for Medical City Dallas. And Dr. Preeti Kohli, and she's a breast surgeon and the breast program director at Monmouth Medical Center. Next slide. Today on our agenda, we're going to be talking about lymphedema across a variety of aspects. The first being early detection and intervention for subclinical lymphedema and why that's important for our patients, and Dr. DiPasquale will be covering that. I will handle going over the latest in clinical practice guidelines and some updates for the PREVENT trial analysis. And then finally, we're going to talk about operationalizing a lymphedema surveillance program and best practices for implementation and compliance, and Dr. Kohli will handle that. As we go through the session, we will take questions via the Q&A function, and then we will handle those all at the end as a panel. So feel free to type in the questions as you go, but we will not be breaking during the presentations to answer the questions. We'll handle them all at the end. And so with that, I will turn it over to Dr. DiPasquale.
Thank you, Dr. Chen. Welcome, everyone. Thank you for coming today to hear all about a lymphedema prevention program. This has been something that's been really near and dear to my heart since starting my practice. It's something that we can help prevent and something that we cause as surgeons. So I think taking ownership over this is really important. So thank you for joining. Next slide. So this is improving survivorship for breast cancer patients. I actually don't call it survivorship. I like to call it livingship, because I think if you're just surviving after having breast cancer, I think that sounds pretty miserable. So I always call them living cancer-free. And when we talk about living, you don't want to have things that can impede your life, stop your activities of daily living or going back to your normal activities. And lymphedema is one of those. So we have over 290,000 people who are diagnosed with breast cancer every year, and 3+ million breast cancer survivors. 1 in 5 patients can get and develop lymphedema. This, again, can change how they live their life: isolation, depression, economic burden. There are lots of things that come with lymphedema. 82% of breast cancer patients are at risk of armed lymphedema due to their treatment. This includes surgery from surgeons, radiation, and taxane-based chemotherapies. 92% of patients who enrolled in a preventative program using the SOZO program and the LDEX program that we had can have complete reduction of the lymphedema and normalization of it. So really looking at the PREVENT trial, we're going to jump into that with Dr. Chen, talking about how we can prevent lymphedema in patients by early screening and detection. Next slide. So breast cancer-related lymphedema factors, we all know surgery, axillary dissection. We do less and less of those, hopefully not very many nowadays. But even sentinel lymph node biopsy can disrupt the lymphatics. There are a lot of lymph nodes that can cross over to the arm and to the breast itself. And it also is related to how big of size we make in the axilla. If we're used to making very large incisions and we're tracking through a lot of those lymphatics getting down, you're still taking out a lot of that, that tracking of the breast or the arm to the lymph node. So you can disrupt lymphatics even by doing a sentinel node. Radiation therapy as well, especially if they're doing comprehensive nodal radiation, and our taxane-based chemotherapy can also contribute to this, as well as patients with diabetes or BMI greater than 30. So 82% of breast cancer patients are at risk of lymphedema with these categories. Next slide. So this here is a study done at MD Anderson. It was published at MD Anderson, radiation therapy, and it shows that it significantly increases your risk of lymphedema. You can see that with a sentinel lymph node alone, and then you add in the radiation, it can twofold increase. And as you go further and further with more surgery, more types of radiation, including boosts, you can get a 6.5-fold risk of getting lymphedema with this. Next slide. The lymphedema stages here are green to red, and you'll find that that kind of correlates with what we'll show you on the little SOZO printout that we have. It'll be green in the green zone, subclinical if it's going up to yellow, and then down up to red is irreversible. So we want to find it way over in the green zone, the subclinical stage. The patient has no symptoms of this. This is our opportunity to intervene and prevent lymphedema and watch that number go normal again. So this is where there's no apparent swelling, but the BIS or the BIS can detect this in the early stages. Stage 1 is when you start getting accumulation of fluid and protein. There's some mild swelling that can occur, and it can wax and wane, and this is stage 1. As you further go into stage 2 and stage 3, these are now irreversible. So this is causing lifelong problems, having to, bandage the arm, going to physical therapy, stopping jobs. Lots of lifelong issues can develop in these irreversible stages. So we're going to focus on this green zone, which is what the machine will help us do. Next slide. So this is where it's well established that early detection and intervention reduces the rates of chronic lymphedema. So we know in sub-zero clinical stage, we can get 100% reversal of lymphedema if we find it before it goes into stage 1, 2, or 3. Even stage 1, if they start to trend up on their SOZO, we can put them into lymphedema therapy, and we can watch that go back to the green zone after a couple treatments. But once we hit that red zone, which is what we've been doing for years by just measuring a patient's arm, it's already irreversible. Next slide. So prevention and early detection is key. I always tell my patients this is called screening SOZO, similar to a screening mammogram. We all know that mammograms save lives. It can find cancer in early stages before the symptoms, which is treatable and curable. The exact same thing is with SOZO. We can find this when they are starting to trigger, which you can see going up into the yellow zone there from their green zone. This is reversible. After treatment, that patient trended right back down to the green zone. Next slide. So lymphedema prevention depends on, again, early detection. Right here, you can see that trending up, right? Normally when they have symptoms and therapy begins, it's already in that red zone or too late to reverse. It's already irreversible. So really, the opportunity for us to do anything is in that subclinical lymphedema. Next slide. So 75% of lymphedema develops in the first 3 years. And so that's a great opportunity as breast surgeons or medical oncologists, when we're still following patients quite closely, to intervene and to put them on a simple less than 1 minute scale to get their monitors. So we can find in the first 3 years, that's when it's going to highly develop. And that's when we're actively seeing them quite often. So it does correlate nicely to coming into their clinic visits. It's not adding extra visits on. Next slide. So this is ImpediMed's bioimpedance spectrometry, and this is what it looks like. So you can see on screen left there, this is very subjective, measuring someone with a tape measure or with their fingertips, and there's optical scanning and lymphography. Those are very time consuming. This on the right-hand side is the SOZO, where they just stand on it. Takes less than 1 minute. They wet their hands and their feet, and it can be done anywhere. In the hallway is where mine is. So very, very easy to do, like a scale. And in less than 1 minute, it generates their score. And you can get a baseline, which will show, and we can follow that for a patient, quite easy. Next slide. So here we can see when do we decide to go forth with treatment? Well, trigger is when it's gone 6.5 or more above their baseline. So the optimal patient would be identified prior to surgery or any surgical intervention and to get a baseline. And then we'd follow them sequentially every 3 to 6 months afterwards, depending on when they come in. And if it goes up to that subclinical stage or past the 6.5, that person would be triggered to go into physical therapy and lymphedema prevention therapy. We all know that physical therapists and lymphedema therapists, especially in rural cities, are really few and far between. And so this is a great way to use these limited resources by sending the patients that actually need it and can have complete reversal of their symptoms at the appropriate times, instead of either sending everyone or sending no one. So it really helps the surgeon or the medical oncologist or the NP who's in clinic doing this take control of that for the patient. Next slide. So here's what their LDEX report can look like after several times coming in. So it's color-coded, very simple and easy. I have my patients come in and we call it the 5th vital sign, and they can't wait to jump on their SOZO to make sure their lymphedema is not there, or do they need treatment or therapy. And we print out their reports and they take them with them. They put them into their little folder where all of their records are so they can monitor this. And it's very easy to read. As you can see, green is good, yellow is caution, and then red would be something where we'd be very concerned about. But our goal here is not to let it get to red. Our goal is to keep it in the green zone. If it's triggering up towards that yellow, we get them into therapy and we watch it drop right back down to the green. Next slide. So the PREVENT trial is more of what Dr. Chen will go through with you, but this is level 1 evidence. It's a large randomized controlled trial. It's over 1,200 patients with breast cancer, and there's 3-year follow-up because, again, we stated the highest risk of lymphedema is within the first 3 years. There's 10 centers across the country and across Australia. And what it showed is that 92% of patients with early detection using ImpediMed's technology and intervention, they did not progress to chronic lymphedema. They never got to the red zone. They're back living their life, and they have no lymphedema. Next slide. So the prevention program really starts with, we test patients. We identify the correct patients, ideally, again, baseline, and then year 1 to 3, we do every 3 months, year 4 to 5, every 6 months, and then year 6+ annually. Now, I can tell you that some of my patients that only come in every 6 months in year 1 to 3 will just come in 6 months if there's no problems. It's not saying you have to be at 3 months, but this is what the PREVENT trial looked at as the optimal way to try to find these early triggers and get them into therapy. So the trigger we talked about is when it jumps up 6.5 above the baseline. And then the treatment, they're sent for at-home treatment, sometimes with physical therapists, compression garment. They come back in and we watch it trend right down. So this is just transient treatment to get them back to normal. Next slide. So treating before progression is critical. So we have stage 2, which then progresses to cellulitis, and again, irreversible. So we cannot change the disease process, but we can leverage the data provided by the machine to help mitigate this clinical lymphedema onset. Next slide. So we help patients avoid the chronic lymphedema. We all know that this is very costly to the patient, to the insurance companies, and ultimately to us as healthcare providers. We can get them with early lymphedema treatment at home. Compression garment, self-massaging. They learn after 1 or 2 therapies with a physical therapist how to do things at home and take care of it and the things they want to look for. If we progress to the chronic lymphedema, this is where the surgical strains or the money strains come on in the system. There are some surgical interventions. There's hospitalizations for cellulitis. And then they need chronic physiotherapy and pneumatic pumps. Next slide. So I encourage everyone to run their numbers. So this is looking at, for every 100 breast cancer patients monitored with LDEX, instead of tape measure, 11 fewer got chronic lymphedema, $25,000 annual patient out-of-pocket cost savings for these women, $160,600 2-year healthcare cost savings caring for these women. So really, it should be a standard approach for prospective breast cancer-related lymphedema surveillance. It takes the burden off of the system, and we're trying to be cost-effective in every way we can nowadays, and this is definitely one way to help. Next slide. Guidelines. There's so many guidelines that support the BIS monitoring, including the NCCN, the American Societies of Breast Surgeons. All of these are very big names out there, and they all support using this, including the NCCN, which updated recently, discussing that this should be the preferred method, not measuring, not doing anything else. Next slide. So looking at my year, everyone asks, well, why do it? Besides the fact that it's the right thing to do and it helps a patient, it is financially beneficial to a surgeon or to a practice, because when we charge for these, insurance companies are now starting to pay. We have payers that cover this. So in my 1 or 3 year looking at this, and my 1 year, this is 1 year data, there is a positive $41,000, $500 made out of this, doing just BIS monitoring of my patients. My total test average, we're about 47 per month. New patients, about 28 per month, which can go up and down, but that total test average will just continuously go up as you add and add and add. So even if you're considering this program in terms of the cost benefit, you only need 7 to 10 patients per month to break even by getting one of these machines in your office. So not only is it the right thing to do, we're helping people, is it's actually beneficial to the surgeon as well. Next slide. So how do we do it? Again, the 5th vital sign, I think it was Pat Whitworth that coined that term, but it really is true. It's so simple and easy. It's just like getting someone's blood pressure, weight, they hop on the sozo and they go in the room. Next slide. So here I have a playbook where I detail every step of the way, going through, well, how do I do it? So my staff identifies the patients. I even do it on existing patients prior to, even though they don't have a baseline. But patients from, my old partner that was here 20 years ago, we still will get maybe a baseline SOZO on them and trend them to make sure it's not already elevated. And the machine you can put at baseline or no baseline based off of if they've had surgery or not. My office will then chart prep and get them into the system. The patients have the education by myself and by my staff, and there is a video as well that Sheldon Feldman had put out there, which is great for patients for education. And then we document and we put this into our medical records, and the patient gets a copy. They love it. Next slide. So this is where the patient then goes to surgery, and then we start following the prevent protocol, where they come in every 3 to 6 months, depending on if they're coming in or not, and if they have any triggers, and we'll continue to follow them for the first 3 years. Then after that, we go every 6 months, and then annual for year 6 on. And this was provided, all the nurses' visits also do this as well. So my nurse navigator, my nurse can also do this. If a patient jumps in and says, hey, I want to get my SOZO today and I'm not in clinic, it's something they can also do and charge for. Next slide. So ImpediMed has a lot of support that helps with this program. So not only do they help get you the product, but there's a whole playbook that they'll make for each and every one of you that is interested, but they go through clinical education. So they have lots of clinical education for not only you, but the patients. They help with workflow. Where is it going to be the best? Where should we put the machine? How do we do this? How do we not disrupt your clinic, which is busy, by doing something that's beneficial? They also help on the reimbursement side. We have a code now, a CPT code that gets covered by many payers across the country. And if any of the payers are not paying, they have a whole reimbursement team and a revenue cycle management team that will help with that. And there's also unique marketing tools that they also do provide to you. Next slide. So why use this lymphedema prevention program? It's right here. I mean, the guidelines support it. It's in the NCCN, right? It's easy to use and implement. It has a CPT code with coverage, and it's the right thing to do for your patients. Next slide. Thank you very much.
Thank you. So the next thing that we'll cover is just where we are in the clinical practice guidelines, and then a little update on some of the PREVENT study. Let's start with the next slide here. One more. So really the principles of lymphedema, and these primarily come from these NCCN survivorship guidelines. I know many of you will be shocked to find out that there is in fact a survivorship guideline, but it is actually linked from the breast guideline as well. So in lymphedema, we start with early detection. And as Dr. Di Pasquale just said, stages 0 and 1 are what we consider to be the reversible stages. Once you get to stage 2 and 3, they're less responsive to treatment. At that point, you're just trying to control symptomatology. You're not trying to get them reversed really so much as just trying to control them. And so therefore, it makes sense to continue to screen people for their risk of lymphedema by symptoms, by clinical exams, and then if available, by bioimpedance spectroscopy. And we need to take the time to educate our patients early and often about what are the symptoms and what are the signs of lymphedema, including such things as fullness, tightness, heaviness, and pain. All these are signs of early lymphedema, but they're already becoming clinical into stage 1 by the time they present you with symptoms. Next slide. As you can see here, again, these are the stages, and you can find them in the NCCN guidelines. And Dr. Pre-symptomatic, stage 0. And in stage 1, you have some symptoms, but by and large, they will reverse with elevation. And this is where you have that opportunity to reverse them with compression and get them to stay reversed. In stage 2, you start to see pitting edema. And then when you get to stage 3, you start to see these big skin changes, and you start to have all the other problems. And hopefully you don't see too many of these anymore. In the next slide, you'll see the lymphedema surveillance workflow. And here we are with having the left side where you start with screening. And the top part of that is about asking the patients. If you don't ask the patients, by and large, they're not going to tell you about subtle symptoms. But then you can see a whole number of objective things that you should be looking for, from changes in range of motion, change in circulation, but importantly, functional mobility. And then if you have the opportunity to get an objective measurement to identify these early signs of lymphedema, including bioimpedance. And then if you see something, work it up. Do a formal volume assessment. Make sure that they don't actually have lymphedema because they have a recurrence. And then if you're thinking about something like lymphatic bypass, something like that, lymphoscintigraphy can also be helpful. And then send them into treatment. And the primary treatment, as we talked about before, is compression. And doing compression with the help of a certified lymphedema therapist, if you have one available, or a physical therapist who can help you with lymphatic drainage, can help you to get this to reverse. And then from there, you go on to the long-term surveillance. On the next slide, we have the footnotes for this one. I'll put them up there for just a second so that if you go back and look at the recording of this, you'll be able to look at it. And in particular, you can see there are links on how to find a certified lymphedema specialist, as well as physical activity and things like that. Next slide. So as you get into surveillance here, again, we want to make sure that we're treating people appropriately. If you have them compression, make sure the compression still fits. As their arm starts to shrink, you may need to refit them for compression. Replace them as you need to. Importantly, now Medicare does cover compression garments. For those people who were having trouble affording them before who are on Medicare, Medicare does now cover them. Check their range of motion, make sure they're actually doing the exercises. For the number of times that you prescribe things that people don't do in lifestyle changes, this is one as well. And this is again where having an LDEX score that they can monitor can be very motivating for patients to try to say, hey, it doesn't look like your LDEX is coming down. Are you actually doing your exercises? And as often as not, people fess up and say, well, I'm not actually doing the exercises. And say, well, are you wearing your compression garment? Well, I wore it for an hour last week. These are the types of things that measuring your LDEX can actually help you start those conversations again. Next slide. And then education here. So we want to make sure that people are being educated as what to look for if their lymphedema is progressing. Are they having redness or having pain? Are things getting worse? And are they also doing things that they don't need to do? For instance, a lot of people think they shouldn't lift anything or they shouldn't do any weight training. But in fact, doing progressive resistance training or light weightlifting can actually be helpful when done in the right way. Water exercise is a good thing. And then we often all have patients who say, I'm never going to get on a plane again or anything like that. And the data is really not there to tell people not to get on a plane or not to get a blood pressure done. However, given the anxiety that's around it, both amongst patients, but also around caregivers and physicians and assistants, um, I, as well as the NCCN, often tell people, well, if you can avoid getting it done on that arm, avoid getting it done on that arm. But I also tell them, if that's the only arm that you can get blood from, then by all means, get a blood draw as opposed to someone trying to draw between your toes or something crazy like that. All right, next slide. Again, here are the footnotes just for references. I'll leave them up there for a second so that people can see. But again, the footnotes around like guarding techniques and safe pet care. Certainly, we want people to be safe, but we also don't want people to be taking their cats and dogs to shelters unnecessarily. Next slide. So here we are for principles. So again, principles of physical activity. Lymphedema is not a contraindication for physical activity, and certainly risk of lymphedema is definitely not a contraindication for physical activity. You don't need to do anything special. Just be aware of what's happening with your arm. Continue to use it. The less you use it, the more trouble you're going to have. And doing strength training is helpful here. If and here on that bullet point where it says should undergo baseline and periodic evaluations. Again, a baseline can be very helpful to understand what is normal for a woman or for a man who is at risk for lymphedema and how are they progressing over time. Without a baseline, it can be hard to say. Woman I saw in clinic today who has baseline swelling, it's going to be hard to determine whether she actually developed lymphedema without that baseline measurement. Next slide. And then here again is the principles of lymphedema, and also noting that one of the footnotes actually takes you to the NCI website, which has been updated to include bioimpedance spectroscopy. So if people are coming to you and they're searching on the web, the NCI website does include bioimpedance spectroscopy as a option for how to find lymphedema, as well as a number of other things, most of which we would never choose to do routinely, things like MRI and CT scanning and lymphoscintigraphy. If you have a perimetry machine, that can also be a good use of finding changes in volume. But bioimpedance will help you find that preclinical as early as possible. Next slide. This was a poster that we had up at ASBS, and this looks at timing of breast cancer-related lymphedema over the 3 years of the PREVENT study. And I know this is very small, but for those of you who registered for ASBS, you'll be able to see this poster in the app for the meeting, or you can blow it up real big later when you come back and see the recording. But on the next slide, I go over some of the highlights really here, which are, first of all, again, we had a lot of good follow-up, long follow-ups here. And the most important thing that I think here is that while half the people actually triggered within the first 9 months, I don't know why months was cut off after 9, but we still saw the other 50% of people after 9 months, and there really wasn't a change over time. As you can see, the trend value, the p-value is 0.24. And you can see that grid over on the lower right of the slide, where you can see that after the 12 months, it's a pretty flat number of people who get diagnosed with lymphedema in every 3-month period. And so the conclusion that we drew from this was that you should continue to follow them. It's not just that first year that you're worried about. You're worried out further and further. And between year and 2 and year 3, there's no decrement. In fact, it makes me worry that maybe year 4 and 5, you continue to have a similar amount. But it does make sense that people are coming back less often to follow them less often at that point. But screening every 3 months may actually provide higher levels of detection even into the later years. What we found from this study was that when we looked at the people who had progressed to an every 6-month schedule, even in years 2 and 3, they had more what we call blow-through lymphedemas, where they didn't have lymphedema, they didn't have a trigger before, and then they actually had clinical lymphedema at their next visit 6 months later. And that happened less often for the people who followed every 3 months. So it is some food for thought as you're designing your lymphedema program, that even if you are at an every 6 month, if they're coming in more often, it may be worthwhile to test them more often. And so far, we haven't seen much pushback. I don't know that I would drag people in who are at low risk to come in every 3 months, years and years out. But if they're in your office or they're at your breast center, it may be valuable to have them pop by and stand on the SOZO for a minute. And with that, I'm going to turn it over to Dr. Coley to wrap up with how to build an actual program.
Thank you so much. Um, this has been a great presentation, and I think there's a great foundation that has already been built to understanding why and lymphedema in general and how to get a program started. But I think there's something that can be gained by learning from others' struggles. You can go on to the next slide. So, so you've already learned that early intervention is key. It's our opportunity to reverse lymphedema when it actually can be reversed. We want to reduce the long-term complications associated with chronic lymphedema, improve the quality of life in our patients. And I think it's really key when you're meeting that patient the first time and they're in this whirlwind thinking of their cancer and their longevity, and knowing that we are thinking of their future and them surviving breast cancer and their quality of life years down the road, and the implications of what we're doing in treating them. Next. So, this is basically going to be a review of how I built our program at Monmouth Medical Center, because it wasn't always as fine-tuned as it is now. So really, who's tested, who does the testing, what kind of resources do we need for this type of program, and what does an ideal workflow look like? Next. So the evolution of our program, in 2017, I had a patient who had an axillary lymph node dissection and had 24 lymph nodes removed. She had radiation, she had chemo, she was young and very high risk for lymphedema, and she wanted to find out what she could do to at least be aware of the early signs of lymphedema. And that's when her family provided, they covered the donation of our LDEX unit. And at that time, we were using this to confirm the diagnosis of lymphedema in patients who were symptomatic. And we started then moving towards a little bit more proactive approach of trying to catch those who were at highest risk, not just those who were symptomatic, because The point is you want to be able to do something about it. As you saw earlier, those later stages of lymphedema, they're not reversible and not at the same rates as if you're catching it subclinically or in an earlier stage. Now, kind of like when tomosynthesis first came out and it wasn't being covered because they thought it was experimental, even though we knew it was fantastic, this was not being covered then because it was considered experimental. And patients were, the system didn't know how to handle this, and the patients end up getting bills, and it could have been as high as $400 or more. So what happened was these patients didn't want to be retested. They'd come back in still having not paid off that prior bill. They didn't want to get retested. And just knowing that even if our system agreed to cover Medicare coverage rate, they wanted the patients to sign an ABN, and just signing something that said, I might have to pay for this, and that knowledge of a bill led to a lot of patients opting out of the study. So the highest risk patients we were trying to screen were the ones who weren't getting screened. It was extremely frustrating, and it was us missing our opportunity to intervene. Next slide. So what we did was we moved to testing everyone, because we've all seen people that have had lymphedema with a sentinel lymph node, and we've seen patients who have had an axillary lymph node dissection who haven't had lymphedema, and there's not really a rhyme or reason to it always. So we needed to really cast a bigger net to succeed, and we wanted to reassure everybody that we are keeping this in the back of our minds as you progress on your care journey with us. So we're testing all at-risk patients. Anyone with a cancer diagnosis gets a baseline. And then after their surgery, anyone who's had lymph nodes excised, whether it's one or several, they get follow-up measurements. We moved our unit to the intake area so it was more accessible. It was previously in a private exam room. And I would say what's probably been key to the success is really working closely with ImpediMed's reimbursement support team. They have been fantastic and really helped us get a lot of coverage. So they were able to get EMR access to our system, Epic, and that's where they would access information for claims. We would get pre-approvals and work with our finance team to go through the appeal process if not covered, drop the charge if we could. And so as we tested more patients, as we continued to submit to insurance companies, this larger volume of patients, we started to see that more and more providers in New Jersey, insurance providers, were covering it. And it also was very helpful when NCCN guidelines were updated in March 2023, where this was no longer considered experimental. So we are now, in the positive. It's actually revenue building, revenue generating, and not something that felt like it was a burden. So you can go to the next slide. So you can just kind of see the trend of how this evolved. 2019, how the volume really dropped down when patients were aware of a potential charge, and how the volume really picked up when we started testing everybody, and when claims started to be adjusted, and when there was coverage being built, and when we made it much more accessible to more patients too. Next slide. So we have quite a few follow-up measurements that are being done. This is just looking at our new and follow-up measurements by year from 2022 to 2024. And I will say that if you look at the next slide, this is almost breaking it down by quarter. It really is important to have this as a team approach, because when I had a very, very good MA or LPN by my side, she was able to work this into the rooming process very seamlessly. And when I didn't have her, the number of patients that were being tested dropped because they just couldn't handle it. So it's important to make it a very streamlined process, and to make sure that everyone's on the same page and that it's a team approach doing this. Go ahead to the next slide. So we've seen the slide. So how we're doing it, we're testing Ideally every 3 months, but similar to other practices, I'm not going to call a patient in who's asymptomatic at 3 months just for a SOZO measurement. Usually it's every 6 months. If there's a 6.5 change, then that's our trigger to treat. And at our system, we refer patients to physical therapy for lymphedema exercises, compression garment fittings, lymphatic massage. And if we do have them come back after we've had that trigger to treat for a repeat measurement. And if it's refractory, then we might refer for a lymphatic pump and see if they need the next level of intervention. Next. So this is actually, I'm not sure if this video will play, but I think it's very helpful to see how quickly a SOZO measurement is actually done. So this is my medical assistant who walked a patient through a SOZO measurement, and she actually was symptomatic. So if you could play this video, I think it's a great example of how this is done. There's no sound. So she's basically, you can play it, I'll just talk you through it. So she's basically wetting down the hand part where the cradle where the patients will put their hands. She also, that's with a baby wipe. She's wiping down the foot part. The patient takes their shoes, socks and shoes off, and any jewelry that's on their hands before they get on the unit. It's very quick, so sometimes they need to put some lotion on if there's not enough contact or moisture to pick up the bioimpedance. But so the patient gets on, and then you can see that there's a tablet, and it's a very quick measurement. It takes only a few seconds. This is Mary Ellen just putting in the date of birth and trying to hide the weight of the patient when she's putting it in. And as you can see, there's a countdown going on. And then before you know it, there's her measurement. And you can see that this patient's measurement is pretty out of range, elevated. Granted, she did not have a baseline, but we didn't need a baseline to know that that was certainly abnormal. And it was a definitely, very validating thing for the patient to know that they weren't crazy. They had symptoms. They felt heaviness, very subtle. If you're looking, there were just some veins on one side that were a little bit less prominent. There, some of the joints didn't look as, thin, and there was some bogginess to the upper arm on one side, but having the measurement validate it was really helpful. And she definitely had a great resolution of her symptoms once we sent her to get a garment fitting and to physical therapy. So we can go on to the next slide. So, implementing this into clinical practice, I think the key elements were, where is this unit? So it's at our, intake area with the vitals. The clinician is really, it's my assistant or my medical assistant or my nurse who's doing this as part of her intake. As you saw, it was very quick. It was less than 30 seconds. The benefit of this as, compared to other ways of measuring is this is highly repeatable. It's not very user dependent. You can compare measurements very easily. And it's integrated, it's automatic, and this can interface with your system's EMR if you want it to. What I do is my MA will come in with the tablet if it's abnormal and show me, and she'll print out the abnormal reading so that the patient can bring it with them to physical therapy if they want to, or if they want to keep it in their records to prove to themselves that they have an improvement at their next measurement. Next slide. So basically, what does the physician have to do? I think it can be daunting taking on any new thing, even if we make it sound so easy. It's just 30 seconds, but it really is. So basically, the staff does the test. They order the test. It drops into my Epic, and I approve the order. They document, my nurse documents. Oh, hold on 1 second. The nurse documents the sorry, my slide just went away. The nurse will document in the EMR exactly what the measurement is with the verbiage needed. And then she will, let me just, Make this bigger, I'm so sorry. Having a technical issue right here. Okay, sorry about that. Are you able to see slides? I'm for some reason not. Let me just switch to. Okay, there we go. So sorry about that. So she will order the SOZO test. She'll document the results. That is easily dropped into my EMR note. So it's a shortcut that will be dropped right in. And then the billing code, the CPT code is also going to be entered by my MA, and that is also automatically done by them. The main thing that the physician has to do is they are just going to look at the score when the patient's thing is either printed out for them or when the MA comes in with that tablet. We're going to look at the score and we're going to interpret it and say, is there a 6.5 change? Does this patient need to be referred? Sometimes you might need to actually just look through the trend and note, was there actually a baseline measurement noted in the past? Because that can change the entire trend and the graph that you'll see. Next slide. So in total, my practice has done SOZO measurements on 526 patients, probably more now, but this is basically going up to 2022. And the number of patients that were triggered were almost 15%. And I mean, that's a huge amount of patients that were given an opportunity to really have their lymphedema reversed. Next. So the code that's going to be entered, 93702, is a CPT code. There is RVU reimbursement. There's also, payment that is more consistently around that $148. The codes that you're going to be entering or your assistant will be entering are either the breast cancer code or lymphedema. And there is this little snippet of the verbiage that's been used. It's been created as a shortcut in Epic. And it basically is very quick. It's a dot phrase, and it'll be entered in, is this the patient's baseline measurement, or is it a follow-up measurement? Is it within normal limits, or what is the value? That is very, very helpful to at least have, if there is a measurement that's not approved, having this documentation in there and explaining why we're doing SOZO or LDEX is very, very helpful. So in New Jersey and regionally, we've had pretty good success in getting coverage. Cigna, United Healthcare, Horizon, Blue Cross Blue Shield in New Jersey, and Federal has been, definitely covering this consistently. Next. The reimbursement support team, as I mentioned before, is really a very, very great asset to the ImpediMed program. And they can work with your practice to create the best workflow, a pre-authorization process. They will help in providing some template letters, documentation for medical necessity. And really the goal is we want to facilitate access for the patient. I have worked directly with Blue Cross Blue Shield. We have been talking with, through peer-to-peers with physicians at insurance companies and explaining why and, the benefit to the patient and the data behind it, like the PREVENT trial. It's extremely helpful. And if you have an opportunity to do that, I mean, it certainly is of benefit. With the pre-service reviews and these pre-authorizations, we've been extremely successful, and only one case was not approved to date. So it can be discouraging at first to hear if it's not approved, but the process of appeal is very, very successful in the end. Next. So the challenge is you want to convince your program that this is a worthwhile thing to do for your patients, that a lymphedema prevention program is actually a great idea and that it can be profitable. So get your organization behind you, looking at the big picture for the patient, that there's a push for survivorship and quality of life after cancer care. It is cost effective and it's going to be quick to improve the level of care for your patients. And SOZO meets all of these goals, and it gives a competitive edge if you have this and your neighboring facility doesn't have it. You can certainly secure reimbursement coverage with the team support. I would suggest, if you can avoid balance billing the patient, that would be definitely better in terms of getting patient compliance. And you want to just create a workflow that's going to align with best practices without making it so burdensome for the staff. I think that's one thing, is if the staff is really feeling that this is a big project for them, and it shouldn't be, it should be very quick and easy. That's when you'll see that it doesn't actually follow through and happen. So test everyone, make it easy, put it in the vitals area, make the documentation straightforward, and it will be definitely possible. Next. So, I mean, really the outcomes are, we've been able to create the best program for our patients, paving the way for successful survivorship. The system, the practice, they're definitely going to make back their investment, especially if you're testing all patients at risk. And down the road, healthcare spending is certainly going to be decreased, especially the slides that you saw earlier with Dr. DePasquale, how much it costs per patient and for the healthcare providers if someone does have lymphedema. And you're just elevating the care of your cancer program. It's the right thing to do. It's the best thing to do. So that's all I have. Again, just a quick summary of all of these. Test all patients, make it easy, streamline the orders, use reimbursement support, and work on the downstream of who you're going to refer to once you get that trigger. Next, thank you so much.
All right, thank you. We have a few questions in that have been submitted. Please feel free to submit more questions as you go, and we'll try to get to as many as we can. The first question we're going to handle, actually, because I think this will follow nicely with what you were just talking about, Dr. Foley, is someone asked how do the results drop into Epic? Does it go into a work queue or in basket? And I will say from the ImpediMed side that we have worked with a number of sites to either set up worksheets for them that they want to import, or I know that some people import them as documents. How do you get your results into Epic, or do you?
It's going to be with that dot phrase that is entered by my nurse. So it's basically the patient had a follow-up measurement. It was this today from this last time. And then if there's any need to refer a patient out, then I will document a little bit further than that. We don't have it currently integrated automatically with Epic. And if the patient wants, they can have that image scanned into the media manager in Epic if they want a copy of it, or reprint it and give it to them.
We also, the SOZO does come with its own software where you can check up all the results of all your patients and categorize them in a variety of ways. So you can also use that as well. Dr. DePasquale, how do you handle keep track of all your patients?
Our nurse navigator.
Excellent.
We've got an awesome nurse navigator, and also we test everyone, just like Dr. Coley says. So it's very easy to keep track of them and update them.
We did have a question about payment in Arkansas specifically, and this question comes from Anas Abdur Rahim, and they're asking that it's still getting some denials, and they haven't had as much success with appeals. And they were wondering what ImpediMed's doing. And I can tell you that we do have a reimbursement team that continues to work with insurance companies to try to get coverage. One thing that we can do is continue to write letters to insurance companies and help you with filing appeals of language. Dr. Coy, I know you had to go through some appeals. Can you talk a little bit about how you handle an appeal when it comes?
Yeah, so if it was really getting to the point where there would be a peer-to-peer with physician at the insurance company, I was able to provide them with a lot of the data that we have with the PREVENT trial. And I think it was just so new that they didn't quite understand what they were approving or denying. Having a discussion to explain exactly what this was, why it was being done, it took very, very little convincing to finally get the peer-to-peer to overturn that and get it covered. So I will say that the reimbursement support team has handled the vast majority of it. The amount of interaction I've had to have has been very little with the insurance companies. There have been letters that I'm happy to sign, and it's drafted and has all the information, but I will say I have not had to sit there for hours on the phone trying to get this approved again and again.
And I think that's a good point, is letters that go to the insurance companies, and ImpediMed helps to develop these letters, but explain to them why this is an important thing to cover, actually go a long way. And we appreciate that you've signed some, and I think Dr. DiPasquale, I think you've been on a few as well. They do go a long way, so that we do encourage you to try to find a way to bill it, because one of the things that does happen is the insurance company will say, well, nobody's billing the code, so we don't have to cover it. And say, well, no, they're not billing the code because they don't think you're covering it. And so we do have a little bit of a chicken and the egg there.
Right.
Working with your rep and your clinical support specialist, they can put you in contact with the reimbursement teams and work from there.
And you can see it's not very highly reimbursing for a few $100s. To have them see this code entered again and again and again, it almost makes them not want to fight it as much. They can fight that PET scan and waste their time on that over this again and again.
Next question really is about getting surgeons on board and getting them to acknowledge that there really is a risk for lymphedema. I'll leave that to either of you, because you've both had experience with this.
I'll start off. I mean, I think that, we're surgeons, we're unique. We all have our, quirks, but lymphedema is real. And it's very life-changing. And no matter, how small your sentinel incision is, we're not doing axillary dissections a lot, but we can't control a patient's body habitus or the way they drain. We can't control if they've got taxane therapy or radiation therapy, but we can control and do a simple, quick, easy test. So that's what I tell them, is that we all cause problems. Just talk about it. It's not a dirty secret. I always tell patients, this is the risk and this is how I'm going to prevent it. I draw a picture, I show what the lymph node is, and then I say, this is your risk of lymphedema, but here I'm going to jump you on the SOZO machine that's going to help find it in a treatable and curable stage, just like you did with your mammogram. And it just makes sense if you talk to the patient that way. And I think surgeons will catch on. I do also like that from the ImpediMed side, they are going to be doing a drop down, or they already maybe have a drop down of which physicians in the region are doing, using this machine, because patients will Google lymphedema, because they're worried. First they Google chemotherapy side effects, right? Then they'll Google lymphedema prevention, or what is lymphedema, and they're worried about it because they see these horror pictures that jump up. Even though it's low, it's still life-changing if it happens to you. So I do feel like ImpediMed does a good job of calling out the surgeons that are using it. And so that's something, if a patient comes in and asks for it and that surgeon doesn't provide it, they may find another surgeon. So again, this is something that's super easy. And so I think just saying, hey, it's easy, it's the right thing to do. You can help patients. This does happen. You do contribute to it. And by the way, you can also make some money off this if you do this correctly.
Yeah, no, I sometimes I think lymphedema is sort of like positive margins. It never happens to me. It only happens to other people.
Yeah. You just need a better pathologist, Steve.
I think the only thing I would add is, there, with such a push to de-escalate nodal management and that being so much of the discussion, sometimes you still have to do a node dissection. Sometimes you still have to, and that's okay. It's reassuring to the patient to be able to say, I will do whatever I have to do to make sure that you have a good cancer surgery, knowing that I have a way to follow you for any sequelae, that I know I may cause this, but at least I'm keeping it on my radar and watching for it. But I don't want to shortchange you by skimping on something that you might actually really need.
Mm-hmm. A couple of people had asked about how to get in contact with the reimbursement team. Usually the fast way is to go through your rep, but if you're having trouble reaching your rep, you can always email, you can email me, schen@impedimed.com. and I can forward it to the right person. But your rep is typically going to know how to reach them. All else fails, you can always go on the website and put in a contact thing, and someone will reach out back to you. And we appreciate letters from anyone. Um, one more logistics question was about orders for PT, OT, and orders for getting a SOZO measurement. I've seen that most people do have a standing order or something like that. Is that how you guys both do it?
Yeah, my staff will identify prior, anyone who's had a sentinel or getting one will be put an order in.
Right. So yeah, you want a specific order for the SOZO measurement, and most of the time they can set that up for you as kind of a templated order within Epic or Cerner or whatever it is that you use. And then I think the other question, oh, there was one way at the beginning about people with autologous flaps and people with both axilla operated on. As far as the autologous flaps, the SOZO compares one to the other, so there's no reason that an autologous flap in and of itself would cause you to have an issue with using a SOZO measurement. As far as surgery on both axilla, that is a tricky question right now because the way that the current SOZO works is it compares one arm to the other. And so if both arms are truly at risk, you run the risk of missing lymphedema in one arm using the current algorithm. We did used to have a bilateral algorithm, and we will hopefully be bringing one back to the market soon. However, we found that the original algorithm just really wasn't as sensitive as we would have liked it to have been, so we withdrew it. And for now, for people who have bilateral, we do recommend that you get measurements because when the new bilateral algorithm becomes available, you'll be able to reassess all those measurements using the new algorithm. But at the moment, people who truly have bilateral risk, you're going to have to use some clinical judgment. And if you talk to your clinical team, they can coach you through some ways that you can still use a SOZO and understand how that works. And I think that is the bulk of the questions. I'm trying to see if there's any other ones that we didn't cover, at least partially. Okay. Well, thank you everyone for joining us on this session, and thank you to Dr. DePasquale and Dr. Coley for taking their time to come learn and teach everyone. Again, if you have any questions, this is available for review by the recording, but also please feel free to reach out to myself, and we can get you in contact with the right folks at any time. And again, my email is schen@impedimed.com. Very easy to find me. So thank you again.
Thank you. Thanks for having me. Thanks for everyone who joined.